Welcome everybody, welcome to another episode of PEM Rules. And today I have a clinically very important episode. So every once in a while, I actually do practice pediatric emergency medicine, and I have a child in front of me that is in dire straits, in severe respiratory distress. I intubate, I ventilate, etc. And every once in a while, that patient actually has a difficult airway. Now, having a child with a difficult airway is a significant challenge for us pediatric emergency medicine physicians because, let's be honest, we don't practice pediatric emergency medicine and intensive care very often. We're certainly experts in airway, but not necessarily experts in the difficult airway. So I wanted to have a pediatric anesthesiologist, I consider anesthesiologists the difficult airway experts, on the show to come and discuss how do we manage the difficult airway in a pediatric patient. I couldn't think of a better person than my old friend from medical school, Adler, who is a pediatric anesthesiologist. And when I contacted him, although it was hard to find time to speak, he was more than happy to help. So thank you, Adam, for coming on the show. I know you are probably a very busy guy, and I appreciate it. Let me just introduce you to the listeners. Adam is a pediatric anesthesiologist. He is originally from Miami, Florida. He completed medical school with me many years ago, and since then did his residency in general anesthesiology. Just so it happens, he did it at the same hospital where I did my general pediatric residency. After residency, I moved to Pittsburgh for my pediatric emergency medicine fellowship, and Adam went to a different place in Pennsylvania at Philadelphia for his pediatric anesthesiology and cardiothoracic anesthesiology at the Children's Hospital of Philadelphia, aka CHOP. So he clearly got some very, very good education. Currently, Adam lives in Houston, Texas, where he works as a pediatric anesthesiology at Texas Children's Hospital. And I will tell you on a personal note that when I met Adam, he was a slacker. And sometime during the clinical years, he woke up and became this hardworking, super ambitious, super smart student, which I am honored to say was a co-student of mine. Adam, good morning. How are you?
Good. Thank you so much for inviting me, Your Honor. I appreciate it.
Thank you. Thank you for coming. And Adam, what I'd like to talk to you about several things. I think of anesthesiologists as literally the smartest doctors out there. You guys have true understanding of the human body and physiology. You know pediatrics, you know cardiovascular, you know pulmonology. It's kind of like you know everything. And by all means, I am not an anesthesiologist, but I do sedations in the pediatric emergency department. And I always thought of the fact that you can take someone's level of consciousness away and then bring it back with usually no problems. That's kind of like a big deal. So I really appreciate you guys, and I value anesthesiologists and what they do. I truly mean it. And one thing, Adam, that I wanted to discuss with you first is the pediatric patient with the difficult airway / upper airway obstruction or airway obstruction. I recently had a patient who presented with a very big neck mass, and I was considering intubating the patient since the child was so ill. I often teach the residents and the medical students when I'm about to intubate a difficult airway or what I think will be a difficult airway, for example, severe croup or any upper airway obstruction, to me, it means two things. Number one, I need to be ready with a size tube smaller than what I think I need. Number two, I call the difficult airway specialist, and that's you guys. By all means, as a pediatric emergency doctor, I consider myself an airway specialist, but not necessarily the difficult airway specialist. Do you agree with those notions? What do you have to say?
Yeah, so that's a really great point. And this is one of the major sources of concern in anybody who takes care of pediatric patients. And I really think that the approach to a pediatric airway is actually twofold. The first being the anatomic considerations that may suggest to the provider that the airway management may be difficult. And secondly, that you think about the physiologic concerns that can lead to difficulty with either securing the airway device, so like you said, the croup or tracheitis, and or actually providing and maintaining ventilation. So I think that's really just a question that can be broken down into many different aspects. So certainly, if we want to delve into that a little bit further, we'll talk about first the anatomic considerations, because it's probably a lot more common. And even with that, it can be actually broken down into two different groups, such as acquired and syndromic, congenital related anatomic considerations. So when we approach a patient, there's certain things, and I think that's probably the most important thing that I try to impart on those who join me, certainly from other departments and of course our own trainees. What I try to impart on them is really what questions you should ask yourself. Certainly when I did my congenital heart talks, I want to tell people what things should kind of raise your ears should stand up and say, I should consider difficulty, right? I mean, we all know, like, if somebody comes in with a big neck tumor, we're a little on edge, and we're thinking, of course, difficult airway. But, of course, there's those clandestine ones that we really need to be considering. So some of the ones that I think about, of course, without saying, anybody who's got active bleeding, bleeding in the airway, bleeding in the oro or nasopharynx, that can lead to very challenging anatomic related airway issues. And again, these are in no particular order. Patients with angioedema, that of course can be challenging, a little less common in children than adults. Patients with facial or head and neck trauma, whether that's due to the immobility or excessive mobility of facial structures, the maxilla, the mandible. Certainly, we all think about neck instability, but I'd say it extends further than that. Patients with facial asymmetry, particularly those with hemifacial microsomia, anybody who's got a significant facial asymmetry. That, of course, as we all know, people who take care of pediatric patients is synonymous with patients with different syndromes, and certainly those that can be associated with difficult airway. Without saying, anybody who's in a C-spine collar, and or cervical hardware devices such as a halo traction can lead to difficulty. Patients with limited neck mobility or fixed head positions, bad torticollis, for example. I got called to the ER probably about 4 or 5 years ago here for a patient who had extreme torticollis, where their neck was basically fixed in an almost 90-degree angle. And, again, really appreciated that. And we'll talk about, when I get down to difficulty, when to call and when to give a heads up. Certainly that was a patient that you can expect just based on the angulation that it would be difficult. Without saying, anybody with head and neck burns, whether they're acute, especially acute, and even like the subacute burns, patients with, of course, head and neck tumors, prior head and neck radiation, anybody, of course, with a history of difficult intubation, those with limited mouth opening and or TMJ dysfunction. And then, of course, the more common one would be a short thyromental distance. A high Adam's apple would be, it is highly predictive of difficulty with the airway and getting a grade 4 view. Patients with significant retrognathia, and that's can be associated with syndromic type of situations, which we'll talk about in a moment. And of course, we all have patients that just have, some, whether it's a receding mandible, just retrognathia that's not associated with difficult airway or syndrome. I'm sorry, associated with syndrome. Anybody who's got microtia. Microtia is a risk factor potentially for difficult intubation, and anybody, of course, who's had a recent facial surgery. So those are really the things that I think about, and things that should really kind of raise your suspicion that the patient may be a difficult airway in terms of anatomic considerations. And of course, secondarily, like I mentioned, there are a lot of pediatric syndromes that are synonymous with difficult airway. Other considerations that we're going to move to, we talked about, this being, anatomic and actual airway management, but also trouble with ventilation. And it's not just trouble with ventilation. We also have to ask ourselves, would this be something that's better dealt with in the operating room or not? And certainly that's a question that, as an anesthesiologist, we ask ourselves quite frequently, somebody, should they get a bedside trach in the PICU, or should they go to the operating room? Well, it depends. Sometimes the patients are more challenging to move than not. And then sometimes they're more challenging if there's a problem. Would you rather be in the operating theater, or would you rather be somewhere in the ICU remotely? That might be more challenging. So I think that's a really important distinction. Certainly it's not just the trouble with the actual airway management, but let's say, something needed to be done, whether it was by an ENT, a trauma surgeon, et cetera. would that be better dealt with in the operating room where, if a surgical airway or other surgical manipulations, rigid bronchoscopy may need to be done in an urgent, emergent manner, it's certainly a lot more preferable to get it done in the OR, versus anywhere else. When I think about those patients, of course, airway foreign bodies is, probably the number one thing that comes to mind. And, I'm sure as you've seen, all the emergency medicine doctors have seen, and of course, you guys are the first line who see those patients. Patients with foreign bodies, it's really best to keep them calm and to deal with that in the operating room. Of course, patients with tracheitis, a little less common in pediatrics, but I have seen one or two in the last couple of years. Kids with pediatric chronic illnesses that do come to the pediatric hospitals, Ludwig's angina, epiglottitis, of course, probably best dealt with in the operating room. So I hope that I answered that first part of your question, Yaron, in terms of, choosing an airway, choosing whether it's a smaller size tube. I hope that, was a good kind of overview of that first particular question. And of course, to follow up, your second question was really about calling for help. So that's a really amazing question. When do you call for help with these type of things? And, this is a notion, and I would say with pretty much all specialties, calling for help early and often can be seen as a sign of weakness, maybe incompetence. And I would say that couldn't be further from the truth. And certainly when it comes to, dealing with people's children and our patients, I mean, that's the last thing that one should ever be considering. Calling for help is certainly preferable. When it comes to potential challenging airways, it is always preferable when somebody calls me in advance. Certainly, if I'm on call, I'm the lone staff in the hospital. I mean, knowing in advance that you're about to intubate someone that you're considering might be quite challenging or has other problems is incredibly helpful. That plus the ability to come down in a calm manner, get the equipment that we may need, really think about things, talk it over. That's really helpful. And like I said, I'd rather always be called to the ER, the ICU, the NICU before multiple attempts at the airway have been made and the patient's been sedated, and then they call it an emergency. I can't tell you enough. I mean, one of my program directors in fellowship always said, endorphins are a neurotoxin. And when you run to a code, when you run to a traumatic event, you get there, you're out of breath. I mean, not just that I'm in terrible shape, which I'm working on, but when you get to a bad situation and you're running in there and the situation's bad, the patient's desaturating, possibly the airway's bloody, et cetera, that is, you're setting yourself and most importantly, the patient up for failure. I can't tell you how many times I've been called after 5, 6, 7 attempts have been made and the airway's bloody. I've seen that with central lines, arterial lines, you name it, lumbar punctures, IVs. Consider being, consider what it would be like being called to the emergency room after 15 attempts at an LP are made, or even 10 attempts to intubate. And it's something that I faced many times. Again, I'm not trying to say that to criticize. This is something that I've spent a great deal of my own mental energy really thinking about in terms of my own practice and imparting to my trainees. And it's something that I like to call perseveration injury. And really what that is when we get tunnel vision. We start to do something and, you just start doing the same thing over and over again. That old quote, doing something multiple times and expecting a different outcome, basically is the definition of insanity. And, the more we do something, the more we attempt to intubate or do an LP or whatever it may be, and it becomes challenging and, it's a difficult situation already. It's an emergency situation. The likelihood of success probably goes down significantly as you get more frustrated. So the two articles that, I do refer people to when it comes to these things, for airway management, I refer everyone to the article on pediatric difficult airway registry data. And that's from the Lancet Respiratory Medicine. That was back in 2016. And they actually identified, many different things in this article, but particularly of great interest is that more than 2 attempts at direct laryngoscopy was associated with failure to intubate in pediatric patients. And that's something that I keep in mind when it comes to trainees trying to really consider, when do I step in? And I think about this, quite often. And the second article is one that I wrote a bunch of years ago with my mentor who passed about a year or so ago, Dr. Lippman from CHOP, who's an exceptional pediatric anesthesiologist, mentor, friend, and human being. And we wrote this article after I saw something that was quite troubling, and it's called When Should Trainees Call for Help with Invasive Procedures? We published it in Pediatrics in 2017. And really, this came about after, watching a PGY, probably 10 or 11 at that point, disappear behind the drape and came out 25 or so attempts at an arterial line in a small baby. And, really just looking at that is quite troubling, maybe even disgraceful to say, after 5, 10, 20, 30 times, at what point do you stop and say, let me ask someone to help? And certainly, if you do look at the article, you'll see the picture and understand that there was a lot of lack of insight there. I hope that answers your first question, your own, a little bit long-winded. I apologize, but try to be thorough.
No worries. Thank you very much. As I'm listening to Adam, I am reminded of my theory that anesthesiologists are the smartest doctors out there.
Got to hang out with more geneticists.
Sure. Yeah, maybe that's true. But I'm clearly, you are a master of the airway and have a very, very comprehensive understanding of the airway. And that's exactly why I wanted to have you on the show. Thank you. Well, that was great. So the second thing I wanted to ask you about is pediatric sedations. So again, I am not an anesthesiologist. I'm a pediatric emergency department physician. I sedate children usually for painful procedures almost daily. I usually use ketamine since it's the only drug I know of that is a sedative, analgesic, and amnestic. You tell me if I'm wrong. And I always have kind of like a set of actions or an algorithm, so to speak, that I follow. So number one, I inject ketamine slowly to avoid bronchospasm, and I usually have no issues. I usually ignore the hypertension that I see on the monitor. I know ketamine causes hypertension, and I always teach the residents and the medical students that most kids have normal, healthy hearts, and the hypertension is transient. I don't do anything for it. And the other thing I teach the residents is that every pediatric sedation should involve soap, suction, oxygen, airway, and pharmacy, aka the meds. It's actually one of my rules. So I wanted to ask you, what are your biggest advice or most important advice for us pediatric emergency doctors, non-anesthesiologist physicians, with regards to sedation?
So that's a fantastic question. And it's certainly something that I've been asked by a number of emergency medicine people. And really, I think the approach to sedation involves asking yourself a few general questions. There's not a one size fits all. Certainly, we'll talk about, the positives and negatives to, adapting these things in terms of, versus protocolizing. So I think the first question is, what are you doing? What procedure are you doing? And, within that, I say, okay, is there pain associated with this procedure? And if so, how long is that pain going to last? So, is there pre-existing pain? If somebody comes in with a fracture and the idea is that they're having severe pain, and this is what I tell people. If I took a grown adult and gave them 10 milligrams of morphine, they probably would either go to sleep, pass out, some would probably become apneic, some, and everything in between. If I took that same person and I broke their leg and I gave them 10 milligrams of morphine, they would probably still be awake and maybe even asking for more. So I think that's a really interesting consideration. So, if you're setting a shoulder where you expect that, or maybe removing a foreign body or suturing up something small, you say, okay, is there pre-existing pain? Maybe to a small degree, but not really too much. The procedure is going to be really short, so I'm not, expecting that I'm going to need this patient to be sedated for a long period of time. And certainly, once I'm done, I really don't expect much pain, if any at all. So maybe I'll inject some local anesthetic, and I think that's another excellent modality that sometimes often gets overlooked. Certainly, we do that when patients are sedated. We're like, oh, they're sedated. They don't. And again, certainly with the longer acting local anesthetics such as a bupivacaine or ropivacaine, those last quite a bit longer. Those can often, blunt the pain from something that's really small. And I think that's an important thing to ask. So obviously, if I'm approaching a patient, for sedation in the operating room and they're having something really short, not painful, 20, 30 minutes, they don't have pain to come in with, they're not going to have pain afterwards. I'm going to think about that differently in terms of my approach to sedation versus someone who maybe comes in with pain and or the procedure is maybe painful and or you expect some pain afterwards. Other things I'm thinking about in terms of formulating my plan, my sedation plan is, what are their comorbidities? Is this a patient who's obese? And of course, within that, what severity of obesity that they, do they have? Are they likely to have sleep apnea? We want to think, what is our setting? Is this a painful fracture, or are we removing a small foreign body in a foot, something that's not too painful? Are we suturing a really minuscule laceration or something a little bit larger? So I think that's a very first important question. With regard to the medications, right, the intent really here is to balance the objectives, like I mentioned above, pain management, sedation, mostly for children, amnesia is kind of an important thing. So really managing that while maintaining spontaneous ventilation. Certainly, there's something to be said about standardizing a practice, whether that's in the dynamic emergency room setting, the dynamic critical care ICU setting. That's definitely an important thing to think about. Learning a little bit more about sedation practices is certainly never a bad thing. And it's one of those things that, it's not a one size fits all, and it really does depend. So, you started off with ketamine. Ketamine works really, really well for all the reasons you mentioned. The large downside that I often find are the massive secretion burden, which can be problematic for a lot of patients, certainly for patients who already have large secretion burdens, CP patients, et cetera. One way to counteract that certainly is pre-treatment with glycopyrrolate or very small doses of atropine if there's no contraindications. That is a really nice approach. So if you are using ketamine and you are worried about that, having secretions, certainly in a supine patient, if they're a little bit more anesthetized than maybe you were hoping for, dripping secretions onto the vocal cords is a risk factor for developing laryngospasms. So, it's just something to consider. So ketamine, you did mention that you push it slowly. I don't think I've ever done that. Certainly, I've used that quite often. I'm not really concerned that would, trigger bronchospasm. As with all these medications, sedation is a little bit different. When I'm giving ketamine, I tend to just give it as a quick bolus, get to the sedation plane that I'm in. Certainly when I'm using multiple medications, and especially like propofol, if I'm trying to maintain spontaneous ventilation, the last thing you want to do is give a bolus of propofol, unless you're really comfortable with using it. And of course, managing if the patient is either hypoventilating or becomes apneic, which is a usual thing, of course, with propofol. Ketamine is one of those things that, you can really just can give it. Certainly if it's a single sole agent that has good pain properties, it's a really good medication, particularly for patients with heart disease, chest masses, which is another one I forgot to mention above, patients with mediastinal masses, and certainly with both airway compromise. I think that's a really important one. So I'm glad we take a second to think about that. And of course, with ventilation. So patients with large mediastinal masses, really want to think about that. But ketamine is a really great medication for them. It really is, despite what the textbooks say. In the textbook, it's not good for pulmonary vascular resistance. In real life, it's really the go-to for many, if not most people, when it comes to patients with pulmonary hypertension. Certainly over the last 8 years, I would say that's the medication that I pretty much always give to patients with pulmonary hypertension. But again, I would definitely defer the medication management. I wouldn't be sedating patients with PH unless you really have advanced training with that and comfort level with that, just because their likelihood for compromise is so high. Dexmedetomidine is a really incredible medication. Works very well, both IV, IM, intranasal, maintains spontaneous ventilation, does provide great sedation and analgesia to a small degree, right? And that's why I said, it really comes to, you have to ask yourself, well, what is this patient having? What is their pain? What is their pain during the procedure, after the procedure, before the procedure? This is a really fantastic medication, even as a sole agent for really short procedures. So say we have the ER, say, I need this patient is really anxious, whatever it may be. They need a very quick CT. Can you help out? It's like, okay, well, why don't you give some dexmedetomidine just to kind of relax them for a really short duration period. I don't tend to do this pretty often. Some practices do it more than others. It's probably more cultural. IM as a sole medication, it does take about 45 minutes for onset of action, as opposed to intranasal, which is about 25 or so minutes, 30 minutes, which is why a lot of people don't use this as a pre-medication, at least in anesthesia, just because the duration that you have to wait is pretty long. IV, of course, is pretty much immediate. You can use it IM for, small procedures, whether that's some kind of sedated scan, certainly for non-painful things that the patient just needs to be calm and sleeping. It does take 45 minutes IM. I don't tend to do it just because it really just doesn't make me friends, very, very many friends with patients and families. I don't like to do too many. I think certainly probably as ER physicians, that's unfortunately a necessary part of your day-to-day, IVs and all these patients. So it's just a little different for anesthesia, but it's a really fantastic medication. I really urge you to consider being part of your repertoire, for a host of things, as well as an adjunct to ketamine. Certainly not, ketamine is not one size fits all. You might need a little bit more sedation. That's a really fantastic medication to combine with ketamine. As far as another medication, midazolam, fantastic adjunct especially when you're looking for amnesia, which is extremely important for those patients who are frequent flyers, and you absolutely know will be coming back for more and more care. So, obviously anybody who's in a peds ER, we do know those patients, chronic medical illnesses, they are going to be coming back quite often. The amnestic part of that is just so absolutely critical for them. So even if you add a little bit of midazolam to whatever else you're doing, can really go a long way. Onset of action, oral 10 to 15 minutes, to really get to that peak effect. And of course, IV is, relatively instantaneous. Of course, I give it a few minutes before I would start the procedure, but really I can't emphasize that enough, certainly for our children who we know have other medical issues, major anxiety, psychiatric issues, et cetera. Super, super helpful and beneficial, not just for the procedure at hand, but for the patient's future. Opioids are an excellent adjunct for the treatment of pain. Fentanyl is really a great choice, and it, certainly minimizes the risks of having reactions to morphine. Sadly, I would say opioids, we always in anesthesia talk about multimodal analgesia, and really, opioids have become like the devil child, and it's really just a shame because it's a very important part. I mean, in addition to OSA, certainly my major focus in terms of my academic part is focused a lot on opioids, and certainly pertaining to patients with sleep apnea. But it's really a shame to see people shy away from something that is important. We definitely want to treat acute pain. It's a major risk factor for chronic pain. Opioids have not caused a problem. Opioids for acute pain in patients in the hospital are not the reason why we have opioid issues in this country. It's certainly not that. It's a topic for another conversation, but really treating acute pain is incredibly important. So, starting off with small doses, 0.5 mics per kilo. I often use a little bit more, 1 to 2 mics per kilo. And the nice thing about that is you really do provide a really solid analgesia with it. It's not, it's not a medication I'm going to use to sedate people, but it's really nice to provide a base of analgesia. With regard to propofol is an amazing sedative for short duration procedures. And it's certainly, one that should be used for people who are readily available to take over the airway. We're always concerned about exaggerated sedation when used in combination with other medications. So certainly if you're giving fentanyl and some ketamine and you're adding some propofol to that. And I think that's really important. Certainly when we think about drugs and doses of medications, I often find this in my really junior trainees. They start quoting me doses. And I say, yeah, that's a great dose for that medication, but you also are considering giving 3 other medications. So you have to take that into account, certainly when we're giving propofol. So if I've given, 1 or 2 mics per kilo of fentanyl, and I've given, something else, dexmedetomidine, and I've given some ketamine, and then I show up in my propofol, the likelihood I'm going to have an exaggerated effect is probably much higher than, when used as a sole agent. So again, it's great medication as a sole agent, but again, when you're doing it in combination with other medications, you definitely want to be mindful. So that's one of those things that give the other medication, wait for the onset of action, give a small amount of propofol if you're comfortable managing the airway fully, if the patient were to become apneic, and, really just kind of see how it goes. As far as ketofol, I actually prefer to use medications completely separately. I don't like mixing medications. In combination, it works quite well. There's a lot of reasons to not mix these medications. Number one, you don't get a homogeneous mixture. It's really hard to know exactly what you're giving. I don't think there's much of a reason. I know a lot of people in anesthesia, may do this. I don't. I think certainly if you wanted to give these two together in tandem, it's not a problem. It works really well. Ketamine as a base of sedation and for analgesia, and propofol, obviously it's not analgesic, but you can use a little bit of extra propofol. Let's just say when you're about to set the joint or you're about to do something like inject the local where it's going to be a very quick, painful experience, a highly painful experience. It's going to last for a very short amount of time. A really small amount of propofol works really well. And again, you want to do that when you're immediately right prior to the painful experience. So, you don't want to give the propofol and then, start getting set up and then, ready to reduce a joint. You'd be like, okay, I'm ready to give it. You tell whoever's giving the medication, the pharmacist, the nurse, okay, push X number of milligrams. And then, within a minute, you're ready to go. And certainly that painful stimulus will, help the patient to, maintain their drive to maintain their respiration.
Very good. So I cannot tell you, Adam, how incredibly important this information is to myself and my listeners. Again, you guys are the experts in airway, the experts in anesthesia and sedations, and those are really, really good advice. Thank you.
There's two last things I would say I want to touch on just to, provide to your listeners that I think are really great importance, specifically when it comes to management of the airway as it pertains to children. The first I would say is the use of the LMA and bag mask ventilation. And very often I've seen people, including anesthesiology providers, they tend to forget the parts of the airway algorithm. They actually just revised the difficult airway algorithm. And I think that reviewing that, frequently often is a really good thing. And it doesn't necessarily mean that you have to place a definitive airway. And I think that sometimes we get really caught up in tunnel visions and say, I have to put an endotracheal tube in. And certainly there are times where that may be true. But when you have initial struggles and or the patient is incredibly difficult, I can tell you, when I have a patient with a really challenging airway, I will often put an LMA in. If I can get away with just an LMA, great. That might be the patient. Certainly if they're desaturating, they're kind of going downhill in the emergency room, you want to do something, you can put an LMA in. For the most part, you can ventilate through the LMA for most patients, barring other related issues. And that's something where you secure the airway, you tape it up, you can bag through it a little bit. Not great enough. You have to generate high pressures, of course, that can be problematic with an LMA, but certainly that's a patient. You can establish a definitive airway later. You can go to the operating room. You can call the anesthesia providers. You can get the fiber optic intubation. There's a lot of things that can be done. And certainly if we have that patient where there's, a couple of attempts made, we want to regroup, pop an LMA in, have them ventilate through it, and or provide bag mask ventilation, either with the mask itself or the bag with the LMA. And it's adequate in most situations. Placing an LMA can really be life-saving. And it really is preferable to maintain ventilation with an LMA, allowing for a more definitive airway management, either in the ER and or in the OR by anesthesia, ENT, advanced equipment, than just to continue repeating to do laryngoscopy over and over and over again. And I think that's just a really critical thing. And the last thing I really wanted to discuss is really determining what is appropriate experience for trainees while balancing patient risk. I think it's really, really of critical importance. Both the article that I mentioned above, anybody who deals with trainees, we should understand this predicament well. And I think it's a balancing act, when you have residents or fellow education versus patient risk, balancing that is really critical, especially when it comes to children. And for me, I balance the resident or fellow level of training with the complexity of the case or the procedure to be done. I don't think the first place to learn is on children. None of us, at least in anesthesiology, we never learn on children. I mean, you don't start anesthesiology residency intubating children, intubating, complex children, cardiac, children with cardiac issues. We don't start learning our regional anesthesia, epidural, spinals. We don't learn that, on children. We certainly learn that in larger adults, which are a lot more forgiving. It's a little bit different. And that's my opinion, take it or leave it. I think that's really important. It's our responsibility as providers that take care of children to sit there and ask ourselves, what is the best thing for this patient? And I hope to leave you with that, because it's one of those things that unfortunately I've seen a lot and definitely weighs on me, where we sometimes forget to ask, what is best for this patient. So I will leave you at that. I'm going to ask Yaron if he has any additional topics of conversation. But certainly, if not, I really, thank you tremendously for inviting me to discuss these aspects of pediatric, airway management and sedation with you. It's really just a privilege to speak with everybody. And thank you again.
Thank you, Adam, very, very much. I mean, again, very impressive knowledge. I'm glad we did this. And I couldn't agree more. I mean, when I started my attending career in 2016, I think my biggest challenge was the balance between my passion and my desire to teach with patient safety and doing what's right for the patient. I think my biggest example was the lumbar puncture on neonates who come in with fever. I mean, I can just get it done myself, or I can give this to the pediatric intern who needs to know how to do them. But that may be challenging, more painful to the patient, etc. So it certainly is something that we all attending deal with, and it's a very, very interesting topic. Thank you, Adam, very, very much for coming on the show. Again, extremely important and useful information to my listeners. I'm going to end, Adam, with a custom that I have on the podcast. I always try, emphasis on the try, to dedicate the outro for the guest who came to the show. So I'm going to ask you, what outro would you like to hear me do in your honor for coming on the show? And it has to be preferably rock music, song that you like, that is doable for someone with minimal talent such as I.
Oh, dude, do not recall all those years we spent in medical school. I'm the last person who knows anything about music. I told my kids that my radio in my car is broken because I like quiet. So I'm going to have to defer to you.
All right. So in your honor, I will probably play one of my favorite songs by Nirvana, who I'm sure you know. And it is called Heart-Shaped Box, one of my favorite songs from their album In Utero. How's that?
Love it.
Awesome. Adam, thank you very much for coming on the show. Really appreciate it. I cannot be more proud saying that this guy, you, was my co-student in med school. Really, truly impressive.
Pleasure to be with you in class as well, man. You were excellent, an excellent medical school classmate.
Thank you very much, Adam. And that is it for today, guys. Thank you very much for listening. Please check out PEM Rules, submit any feedback you have. Also, don't forget to check out EP Monthly to read my monthly column. And that's it. This is Nirvana, Heart-Shaped Box from the album In Utero. Hope you like it.